is just about that appointed time. So I'd like to welcome all the new people and remind them that we still now have 20 more senior experiences that you can come to. So that's one more down, pass them around. And so welcome to do that. And for those new people in the audience, also a reminder that you can watch these on YouTube. Chemistry, Senior, Lawrence, you can get those. And so for our second speaker today is going to be Emily. She was also one of my advisees, so Nick was the one that wasn't. And that just kind of watching them interact and grow up together as freshmen was really rewarding and quite interesting. And just watching them right now reminded me of the meerkats I saw yesterday at the San Diego Zoo, how supportive they are of each other. Very social together. And so it seems like meerkats would probably make excellent researchers, just as a hypothetical. Anyhow, Mary is going to be going, Emily is going to be going, Mary, we already talked about that. Emily is going to be going to the University of Michigan Pharmacy School. Now, it takes a lot of work to go to pharmacy school. I know this because I taught at Butler University, which has a pharmacy school, and that what makes it truly a pain in the ass is figuring out the requirements for each individual school. And then it takes a really special person to sort through all of those possibilities. Lots of patients to draw all kinds of little maps of what class we should go where and how and this, that, and the other. And Emily was fabulous at doing this. And so definitely looking forward to her going to the University of Michigan. I've already promised her I'll bug her for basketball and football tickets because my parents went to Michigan, so I'm excited about that. But anyhow, it's quite the loss to see all three of them graduating. And it's kind of neat that they all gave their talks kind of back to back. Anyhow, without further ado, I will turn you over to Emily. Just as one last reminder, she also did research with Dr. Pepper. So take it away.
Thank you. Good afternoon, everyone. Thank you all for coming. Like Dave said, I did research last summer at Purdue University in the lab of Dr. Philip S. Lau. So today I'll be presenting that research to you. And my project is called Predicting Treatment Efficacy Using a Radioactive Folate Conjugate in Bleomycin-Induced Pulmonary Fibrosis. So I know there's a lot of words in that title, and I want to try to walk you through those step by step. But to begin, I want to talk about the broad purpose of my research. So why was I studying pulmonary fibrosis in the first place? Well, pulmonary fibrosis is a disease that can manifest itself very differently in different patients. So there's not necessarily a typical way to treat this disease. This means that the approach a physician might take is more or less a trial and error approach. They might try a patient on a drug based on it working in other patients or based on it working on other symptoms in different diseases. And this means that the patient might end up on that drug for a long period of time before knowing whether or not it's working in a clinical sense. It might take a while for clinical efficacy to show up. Now this puts the patient at risk of adverse side effects. And this means that the patient may end up taking a drug that isn't actually working for them for a long period of time, suffering from the side effects, and then having to eventually switch to a new drug. So you can see that within this timeline, there is a need for a way to test earlier on in the treatment timeline whether or not the drug is working. And that's what my research is aimed at, not necessarily finding a new treatment for pulmonary fibrosis, but rather at finding a better treatment and a way to predict whether or not that treatment is going to work earlier on. So pulmonary fibrosis fits into the category of diseases called immune-mediated inflammatory diseases. And just to give a general description, an immune-mediated inflammatory disease is a disease that revolves around the inflammatory response. And that's just inflammation. So we've all have some concept of what inflammation means. But this immune-mediated inflammatory disease also involves the immune system. And the immune system is actually contributing to that inflammation. So there are two types of immune-mediated inflammatory diseases. And the first is idiopathic. Idiopathic means that it's arising spontaneously from processes within the body itself. And that is contrasted to the injury-induced variety. So So injury-induced would be due to external causes. For example, in the case of pulmonary fibrosis, an injury-induced version might be caused by the person being a smoker or working in an environment where there's a lot of pollutants in the air. There are a lot of other types of immune-mediated inflammatory diseases, and I want to give you a few more examples so that you can see how diverse they are. So, for example, there's rheumatoid arthritis, which affects the joints, Crohn's disease in the intestines, atherosclerosis in the heart and arteries, psoriasis in the skin, type 1 diabetes in the pancreas, and multiple sclerosis in the brain and spinal cord. So as you can see, this category of diseases is quite diverse. It affects a lot of different organs and the different diseases, and the diseases can have very broad range of symptoms. But they can all be grouped together from this mechanistic standpoint. And the mechanism that draws them all together is the inflammatory response. So to go into more detail about inflammation, this cartoon depicts what are generally used as the 5 pillars of inflammation. And so those pillars are heat, redness, swelling, pain, and loss of function. We probably have all experienced the acute inflammatory response at some point in our lives. So say you get a cut on your hand, it's going to get red, it's going to get puffy, it's going to be painful. So we can kind of understand what this is talking about as far as inflammation goes. And that acute inflammatory response really does exist for the benefit of the body. It's the body's way of trying to protect itself. However, it's when this response is persistent and long-lasting that chronic inflammation sets in. And that can be very detrimental to the body. And that's what's happening in these immune-mediated inflammatory diseases. The inflammation is no longer a helpful process, but it's actually a hurtful process. So one of the main components of the inflammatory response is a cell called a macrophage. And here on this slide, this is a scanning electron micrograph of macrophages. And you can see on the surface of the cell, there's these little protrusions. And these protrusions are one of the key components of the main function of a macrophage at a site of inflammation, which is to do phagocytosis. And phagocytosis is a process by which a macrophage cell can actually engulf other particles. So in the example of getting a cut on your hand, there might be bacteria or other dirt that gets in there. The macrophage can actually take that up, get rid of it from the body. And so that's why a macrophage is really a useful entity for the most part. Another thing that a macrophage does is it can respond to and produce these chemical messengers called cytokines. So cytokines are little molecules that are swimming around your body, and it's how cells talk to each other. So some examples of cytokines that would be very useful in the inflammatory response, TGF-beta is one that is produced by cells that are inflamed. And it's going to talk to the macrophages and tell them to start now going into inflammation mode. Now another cytokine called TNF-alpha is produced by the macrophages to talk to other macrophages and to talk to other cells of the immune system, and again, to send out those signals, this is inflammation time for the body. So when a macrophage is producing these cytokines, it is said to be activated. And there's a very specific way that macrophages become activated. And there's a big difference between an activated macrophage and a not activated macrophage. So I want to walk through that process. Here in this slide, I've depicted the cells of the tissue down at the bottom of the picture. And inside those cells of the tissue, these little yellow dots represent those cytokines I was talking about. So in the case of pulmonary fibrosis, that would be TGF-beta. Up here on the top of the slide is the cell membrane of a macrophage. So on the surface of the macrophage, you can see a cytokine receptor. So what's going to happen is that this inflamed tissue is going to release a cytokine. It's going to bind to the receptor, and now this macrophage is being said to be activated. So the cytokine is going to kickstart a whole signaling event that's going to cause this macrophage to be activated. And the biggest difference that I want to draw your attention to between an activated macrophage and a not activated macrophage is that an activated macrophage expresses new molecules on the surface of the cell. And these are proteins that are upregulated and expressed on the surface of the cell. So they're exposed to the outside environment, and they're going to be involved in signaling. For the sake of my research in pulmonary fibrosis, the most important cell surface molecule that gets expressed on activated macrophages is the folate receptor. And so I just want you to be able to pull away from this slide that the folate receptor is only going to be found in great amounts on the activated macrophages and not on other cells of the body. So it makes the activated macrophages detectable and special. I also want to give you a little bit more idea of pulmonary fibrosis, the pathology of pulmonary fibrosis, and why it is such a detrimental disease. So here on this slide, these are light microscope images. On the left, you can see the lung tissue from a healthy individual. There's a lot of white spaces, and those are the alveoli. Those are the air spaces where gas exchange occurs. So that's what you want to see in a healthy lung. On the right side, this is the lung of someone with pulmonary fibrosis. You can see reduced white spaces, which means that the air spaces had actually collapsed, and it's going to be a lot harder to breathe. And also this thickened purple areas, the cells are not only inflamed, but the inflammation has gotten so bad that now there's scar tissue being deposited in the lungs. And that's what fibrosis refers to, the scar tissue in the lungs. So in my research at Purdue, I was actually working with pulmonary fibrosis in a mouse model. Mice are kind of the go-to model for human disease these days. So in my research, I had to begin on what we call day 0 by inducing pulmonary fibrosis in these mice. And then as the mice developed the disease, I could see a few markers that are classic markers of this disease in mice based on other studies, which would be that by day 7, they're already developing alveolitis, which is the inflammation of those air spaces I was talking about, and the fibroblasts are proliferating, and those are the cells that deposit the scar tissue. By day 14, the mice already had full-blown pulmonary fibrosis, and by day 21 to 28, 3 to 4 weeks into the study, they were said to have a maximal fibrotic response. And by the end of 4 weeks, this is when the mice who had pulmonary fibrosis and weren't treated would start dying naturally. So the mice are very sick at this point in the study. Now, to draw this back to the purpose of my research, there's a few key dates that I want to point out, which would be right here at day 7 when we would start treatment. So I would start giving the mice that were in the experimental group their anti-inflammatory drugs, and they were given those drugs every day. And then a few days later, I would take a picture with the special imaging technique that my research revolves around. And to draw this back to the purpose, this is to say from this picture that yes, the drug is working or no, it's not, before you get to the part of the study where the mice are really sick. So how do I give mice pulmonary fibrosis? Well, there's a standard technique that has been developed and used in multiple laboratories, and it's called an intratracheal instillation. So in general, this involves putting the mouse to sleep. It's anesthetized during this procedure. It lies flat on its back, and you insert a laryngoscope down the mouse's throat, and that allows you to differentiate between the esophagus and the trachea. And then I would put the syringe filled with the inducing chemical down through the trachea so that the drug could be directly delivered right here to the lung tissue. And this model was developed to specifically imitate human pulmonary fibrosis in the mice, and also because it works very quickly. So the mice get sick quickly, and the study can be completed in 4 weeks. The chemical used to induce pulmonary fibrosis is called bleomycin, and it is isolated from this bacterium here called Streptomyces verticillus. You can see on this slide it's a very complex organic molecule, and it was actually discovered or first isolated for the purpose of treating cancer. So this molecule causes strand breaks in DNA, so it's a very good cytotoxic agent, and it did work to treat cancer for a while. However, when the researchers were studying bleomycin as a cancer drug, they determined that a lot of patients were coming down with lung agitation and were eventually developing pulmonary fibrosis. So this drug is no longer used to treat cancer because of the side effects, but it is now the standard chemical used to induce pulmonary fibrosis in animal models. So after giving the mice pulmonary fibrosis, I split them up into the experimental groups. And the first 2 groups, the treatment groups, were receiving anti-inflammatory drugs. So the first drug that I gave to some of the mice is called dexamethasone. Dexamethasone is a pretty broad spectrum anti-inflammatory drug. It works on a variety of inflammatory diseases. And in general, it's part of the class of drugs called a glucocorticoid. And it helps to just upregulate the body's own production of anti-inflammatory proteins. So this is why it can be used for a wide variety of inflammatory diseases. It doesn't have a particularly specific mechanism. The other drug I was using is called Enbrel. And this is a much newer drug that has been invented much more recently. And it has a slightly more specific mechanism. So I think we've all heard antibody before. This type of Enbrel is a part of the class of drugs called monoclonal antibodies. And an antibody is basically a specialized protein. It's made naturally in the body, but it recognizes very specific patterns on other parts of the cell or other things in your body, molecules that are floating around in the bloodstream. It can recognize very specific things. So in the case of a monoclonal antibody, it's produced in lab, but this drug, when injected into a patient, is going to be able to recognize one specific thing. And in the case of Enbrel, it specifically recognizes TNF-alpha, which is that cytokine I mentioned earlier that's produced by the activated macrophages. So the purpose of this drug is to bind the TNF-alpha and prevent it from activating other cells of the immune system, to kind of stop that signaling cascade in order to try to prevent further inflammation from developing. For the control groups, I had the healthy control, so the mice that did not have pulmonary fibrosis, and the disease control, the mice that were induced with pulmonary fibrosis but were not given any anti-inflammatory drugs. So now I want to get into the main experimental procedure of this research. And the topic here that I want to talk about is actually a procedure that was invented in Dr. Lau's lab, and it's called folate targeting. So here on this slide, I've depicted the cell membrane of a macrophage, with inside the cell being below and outside the cell being above. And like I mentioned before, the most important thing about these activated macrophages, at least with respect to my research, is that they express the folate receptor at a high level. So that's depicted here in purple. It's sitting there on the surface of the cell, and the folate receptor is going to bind to its endogenous ligand, folic acid, here represented in yellow. Folic acid is a vitamin. It's a B vitamin that we all need. So it's found in fruits and vegetables. It's now added to a lot of cereals and grains to enrich them. It's something that it's not a scary chemical at all. It's something we all need. It's actually involved in red blood cell formation, DNA synthesis, and repair. So it's an important thing, and it just so happens that it binds the folate receptor and is brought inside activated macrophages. So the fact that this occurs naturally in the body is something we can manifest, or something we can exploit in this research by attaching other molecules to the folic acid. And those other molecules are called the folate conjugate. And when the folate conjugate is chemically bound to the folic acid, it binds to the folate receptor and is brought inside the activated macrophage the same way the folic acid is. So in my research, the purpose of adding a folate conjugate to folic acid and having it be brought inside an activated macrophage is that I was using a folate conjugate called EC20 that is radioactive. So by bringing a radioactive compound inside activated macrophages, I was able to use a special imaging technique to see where the radioactivity was. And by seeing where the radioactivity was, I could see where the activated macrophages were, which is an indication of where the inflammation is and how bad the inflammation is. So to tell you a little bit more about this crazy chemical EC20 that's radioactive that I was injecting into mice, well, this is the chemical structure. It's not too complicated. There are 4 main parts. The first part here is the folic acid. So this is the part that's going to bind the folate receptor and allow the whole thing to be brought into the activated macrophage. And that's attached to the diaminopropionic acid, which is attached to aspartic acid and a cysteine residue, which are both amino acids. So I want to draw your attention here to this pocket created between the 3 nitrogens and the sulfur atom. And that is a chelating pocket for an atom of technetium. And technetium is what makes EC20 radioactive. So that's really the key part here, since the radioactivity is what's required to see anything on the image. So technetium, we all need a little refresher. It's right here in the middle of the periodic table. Probably not an atom you've heard a ton about, but the isotope of technetium that I was using is called 99M technetium. And the M stands for metastable. So just to give a broad description of what that means, a metastable isotope is going to be stable at the excited state longer than would be expected for the isotope of that atomic number. So that means 99M technetium is more stable than 99 technetium. Other really useful characteristics of this isotope are that it has a pretty short half-life, only 6 hours for the physical half-life. And it also is cleared from the body relatively quickly. So it has a half-life of 24 hours for biological clearance. And this means that 99M technetium can be fairly safely used and is routinely used in diagnostic nuclear medicine. So this is not something that my lab was using first or anything. It's been used and is being used routinely right now. And because it's cleared from the body relatively quickly, we didn't have to worry about the mice having this chemical lingering in their systems for too long. So at this point, I want to give you a little bit of a refresher on what I've done to my black mouse here. So starting at the beginning, I induced pulmonary fibrosis using the bleomycin. I started treating the mice with anti-inflammatory drugs, the dexamethasone or the Enbrel. And then I injected them with a radioactive folate conjugate called EC20 that's going to be brought up into the activated macrophages. So at this point, the question in my whole research project is, how are these drugs, are they reducing inflammation? And furthermore, can I see a reduction in inflammation just a few days after starting treatment, before those adverse side effects might start setting in? So now I can show you the pictures I've been talking about that I took with that special camera that sees radioactivity. And here in this picture, you can see that a bright splotch represents areas where their radioactivity has been detected, which would mean that EC20 was brought up into the activated macrophages, and it's indicating then that that's an area of inflammation. So on the far left with the healthy mouse, there's no bright splotch in its lung region, but the disease control mouse has a pretty large bright splotch. And so that's indicating quite a lot of the EC20 was brought up into the activated macrophages. On the right side, in the dexamethasone treated mouse, there's a little bit of purple in its lung region. So it looks like there's definitely still some activated macrophages there that are taking up EC20. But it seems to be quite to a much smaller extent than for the disease control mouse. And this is only a couple days after starting the treatment that we already see this pretty big difference in the amount of inflammatory markers. So the same story goes for the Enbrel treated mouse. Again, you can see this disease control mouse in the middle has quite a bright splotch of the radioactivity here, and it looks like the Enbrel mouse resembles the healthy mouse here. So Enbrel might be doing even a better job of reducing those inflammatory markers, the activated macrophages. So from these images taken very early on in the study, we can start to predict that both of these drugs, dexamethasone and Enbrel, are in fact reducing inflammation. And we can say that because there's less EC20 being taken up by the activated macrophages. So if there are less activated macrophages, probably already the inflammation is being reduced. But in order to bolster these results, I had to do a few more assays at the very end of the 4-week study. And the first assay that I did is called a bronchoalveolar lavage fluid assay. And this involves injecting saline into the lungs of the mice and then pulling it back out and testing that fluid for cells. And basically, more cells would mean that there are more activated macrophages hanging around in the lungs and there's more inflammation in the lungs. So on the y-axis here, we're looking at the cell count. And a higher number of cells is going to indicate greater inflammation. So for the disease control bar here, you can see that one has the highest number of cells, and that's indicating that those mice have a lot of inflammation in their lungs. For both the Enbrel and dexamethasone treated mice, there was a statistically significant reduction in the amount of cells in the lavage fluid, which is indicating that at the end of 4 weeks, the earlier prediction made by the EC20 image was holding to be true, which is that there was actually a significant reduction in the inflammatory markers for both of those drug treatments. The second assay that I did at the very end of the study was the hydroxyproline content assay. And hydroxyproline is a component of collagen, and collagen is the main component of scar tissue. So this assay was measuring how fibrous or how fibrotic the lungs were in these mice. Again, a higher higher hydroxyproline content number is going to indicate greater amount of scar tissue and greater inflammation. So the disease control mice, again, had the highest amount of hydroxyproline. And once again, there were statistically significant reductions in hydroxyproline content for both the Enbrel and the dexamethasone treated mice. So this is, again, supporting that earlier prediction made by the EC20 image, which is a good way to check that, yes, in fact, that picture we took was showing a reduction in inflammation, and it held to be true at the end of the study. So to conclude, what I learned from this research is that this radioactive folate conjugate, EC20, is a very accurate way to predict whether or not a drug is going to work. And this is early on in the treatment timeline before the mice get too sick. And to apply this to human medicine, this drug would be able to allow a physician to take a picture of a patient wherever their inflammation is, whether it's the lungs or the joints or some other internal organ. They would allow the physician to say, yes, it looks like inflammation is already being reduced, or no, it's not. And that's all just based on being able to see where activated macrophages are. And then this would allow the physician to be able to say, yes, this medication is working for you, no, it isn't. And being able to say that earlier on in the treatment timeline is very helpful to these patients who are suffering from diseases that are not treated easily. So I'd like to say thank you to my lab group at Purdue, Philip Lau for being my PI, and also to Lindsay Kellerhouse and Nashini Bandara, the two graduate students that I worked with. And here at Lawrence, I want to thank Dr. Dave for being my advisor for 4 years, best advisor I could ever have. We've had so many adventures. And I also want to thank Ron Peck, maybe he's tuning in. I want to just thank him for getting me involved in research in the first place and having faith in me as a little freshman. And I really want to thank Mary and Nick for going through this process of learning how to be a research scientist with me. It's been a blast, and I just can't think of anything that I would want to do more while I was here at Lawrence. And I also want to thank my very supportive friends and family back home and around the world for watching on live stream. Thanks all for tuning in. With that, any questions?
So did you just take one image of each of the mice, and how long into the study did you take that exactly?
So there were 5 mice in each of the treatment groups. And so we put the mice in the imaging machine, just 3 at a time. So there's actually 5 replicates of each of those pictures. And then as far as the timeline, so it was 3 days after starting treatment that we took the picture with EC20. And they were getting the treatment every day.
And then how long did you have to wait after you injected the EC20?
It was about an hour. It was an intraperitoneal injection, so it gets into the bloodstream pretty quickly and is taken up and processed very quickly as well.
So you would inject that just into the bloodstream no matter where you wanted the targeting, so that goes everywhere, right?
Yep, it will. It will go everywhere. And because of it only being brought up by the folate receptor, other research in this lab has shown that it does not accumulate anywhere except where there's inflammation because of the activated macrophages. It also accumulates in tumor cells because tumor cells overexpress the folate receptor, and then also you can see it show up in the kidneys, but that's only because it's being metabolized there and then it comes out in the urine.
So the reason the picture, the treated mouse, the reason that there's not, is just the mouse just eliminated it before you put them under the picture.
Exactly.
I'm not familiar with using mice. Is there any sort of age requirement for them, or do you take into account how old they are in the
Well,
study?
you buy the mice from a company that specializes in selling lab mice. So they generally arrive in lab around 6 weeks to 2 months old. They let them grow up a little bit before they mail them out to you. But then we do let them get accustomed to their cages for a week before we do any procedures on them. So all the mice would arrive in our lab and sit for a week before we did anything to them.
How do you measure hydroxyproline?
Oh, it was quite fun. So this would be after, of course, the end of the study. So the mice had been sacrificed, and I excised their lungs and ground them up using a homogenizer. And then we would, from there, do a lot of chemicals being added to that to specifically get the hydroxyproline out. That was a fun day.
Thank you very
One
much.
more,
Oh,
one
one
more.
more.
Oh.
Oh, sure, no.
This is kind of a background question, just because I don't understand biology very well. But so I have in my mind that, you know, fibrotic tissue, scar tissue is something that sort of, once it's there, stays there. But you're saying that went away?
No, not saying it went away.
Oh, okay.
So scar tissue is permanent, but treating people with pulmonary fibrosis, that's why it's not a cure at all. It's a treatment to reduce the inflammation.
Oh, okay.
To
So the
try
damage
to
that's already done
prevent-
is not going to be reversed. You're just keeping it from getting worse.